anyone unfamiliar with me, I'm Dr. Saba and I'm working as a consultant cardiologist at an ICU. So we're going to discuss, or we're going to share, or I wanted to share a case with little atypical finding, I would say. Well, I wanted to share your case, an echocardiograph of who was advised when she was admitted in our ward. She was admitted with unstable angina. There was nothing in the past history except for the uncontrolled hypertension. The patient was 40-year female of average height and build. Her serial droppings were negative, and I have myself hidden few of the examination finding in this scenario just for the sake of. This is the case basically. I want you all to make diagnosis as you are looking at the images. These are all transversive views that we got from the patient.
आप explain करना चाहते explain करते हैं सर.
This is a Viper 4 chamber view. I just wanted everyone to contribute into that. If they can come up with some diagnosis.
नहीं आप नहीं कर रहे हैं, interactive नहीं है.
Okay, to me it was a little thickened mitral valve. Otherwise, interrectal septum was thin and a little redundant in this case. And this is suprasternal view, and we got narrowing here with the gradient across the descending thoracic aorta. The P gradient was about 49. That was significant. So we concluded the case as coarctation of aorta till now. But then again, when we looked into the case again and we looked into the views again, we thought we are clear with the case, but it was not the scenario in actual. We re-looked the case. If you can see, I believe I got a pointer here.
Yes. Yeah.
Okay, fine, I can move it.
Yeah.
Okay, fine, I can move this one. So if you can see, there is a little notching in the antemitral leaflet. If all of you can appreciate it. So this was actually the turning point. We start looking into it. Why this mitral valve is behaving so abnormally. And now the whole scenario changes. When you go into some modified views, they were also available in the initial views, but they were not that much clear. We need to make
now
some.
You can ask.
So we got this thing. Can anybody comment on it? Sorry? Double orifice mitral valve. Okay, fine. I'll show you more views about it. So we took more and more images just to get sure about what it is actually. This is how it looked like in short axis. So other than you, anyone else can comment on it? So fine, then transthoracic, we were thinking about double orifice mitral valve. This was our first opinion about this. So we are not very expert in doing the congenitals. We send the patient for further confirmation for transesophageal echocardiogram. And the initial views of LV in transesophageal echocardiogram are like this. So what do you say now? Still double orifice? So we are not sure. The initial views are very like a normal mitral valve. Then we start taking more and more views, and when we are taking at 90 degrees, this was again looking like a double orifice of mitral valve with no significant mitral regurgitation. Then we go into the transtest for the transtestic views. These are the transtestic views that we have, and as you can see in this case, I believe there is a running issue there. There is a fibrous ridge that is obstructing the two. So that is making the two orifices of mitral valve actually. If you can see in the short axis again, there is also a fibrous ridge separating the true mitral leaflet or true mitral orifice into the two orifices, anterior and posterior. Even after that, just to make sure, we take an expert opinion from our head of department of needs cardiology. And with the joint decision, we made this patient to have a bicuspid aortic, a double orifice mitral valve with coarctation of aorta. So you finally concluded the case yourself. So a little about the double orifice mitral valve. It's a rare congenital anomaly. It's very rare, and it's usually caused by a fibrous tissue, which partially or completely divide the mitral valve into two orifices. It can behave normally. Most of the time, it behaves normally. You might not get mitral regurgitation in all of the cases, but can have mitral regurgitation that can be of severe intensity in some cases. It can be divided into three different types depending on the severity of division of orifices. A whole type that has a rudimentary orifice, a complete bridging like in our case that has two almost equal orifices of mitral valve, and incomplete bridging that only have a fibrous bridge obstructing or connecting tips of anterior posterior mitral leaflet. It's usually associated with different other abnormalities like coarctation of aorta, like in our case, VSDs, ASDs, even sinus may also say ASDs, hypoplastic left heart syndrome, and double orifice tricuspid well and short complexes, and many others. Very rare cases, less than 3% of such cases are isolated in actual. So if the patient is not symptomatic, is not having the, actually we are not treating double orifice mitral valve, we are treating MR. If the patient is having significant MR, yes, we're going to treat it. If she or he has not significant MR, we will not be, do anything with double orifice mitral valve. A few take-home message in this case was we should take blood pressure in both arms. This patient was initially misdiagnosed because every time the blood pressure was taken from a single arm. So always coming with uncontrolled hypertension. To auscultate the patient because the patient was referred to us because of the secondary to the murmur the affair was auscultated. Although in this case it was not significant, but it might be significant in some cases. So incidental findings can be significant in some cases. Sure. So always to dig into any atypical finding in echo, you might get something abnormal or something other than the usual finding that can be the cause of the symptoms of the patient. And after that, even if you're having a diagnosis, do take an expert opinion. They will help you out in making a good decision about the patient. At the end, I just wanted to thank you all.
Thank you. Thank you, Dr. Saba. It was really a nice case and a nice and rare case. And I must say that the images are really beautiful, especially the transesophageal images. यहाँ पर हमारे पास मीट्स वाले लोग भी बैठे हैं, so maybe we can take comments online as well as people who are sitting here. Dr. Imran Hamid is also here, so कोई भी यहाँ से comment देना चाहे तो. Online.
Very nice case with the Saba. And the thing of the matter is that you should look at each and everything very, very thoughtfully. The movement of the mitral valve, that was the inspired here for the diagnosis, I think so. And she rightly pointed out that blood pressures should be taken in the both arms and the one of the limb as well. And especially when you get hypertrophy, think of coarctation as an echocardiography. Think of coarctation. Because hypertension and all that, that also leads to hypertrophy. But coarctation is a thing that we miss too often. And if you start looking at it, then you will get that it can be seen very commonly. Secondly, I will make a comment that I think, did you do gap of this patient for the gradient? Yeah. The
patient was kept for the list of intervention, but till now the intervention was not done. It's a week.
Okay. So the envelope of the CW Doppler across the coarctation, I think with a little movement of the transducer, you could have get more gradient. 49 was, I think, so low for this. It could have gone to 70, 75 like the peak gradient. And the sign for the newcomers over here, just that was a very well marked sign of coarctation in the descending curve. This one. Thank you.
Dr. Saba, Can you hear us?
Yes, sir.
जी सर, आपकी
Yes,
आवाज आ रही है डॉक्टर शहबाज।
जी जी मेरी आवाज आ रही है, प्लीज बोलें।
जी जी। अब बड़ा अच्छा इंटरेस्टिंग केस था, खासतौर पे कंजेनिटल एब्नॉर्मैलिटीज के हिसाब से। सो माय मैसेज वुड बी कि जब भी कभी कोई एक कंजेनिटल एब्नॉर्मैलिटी देखे, we must not stop there. Look for other things. जैसे बड़ी किया कि कोऑपरेशन देखी, माइटल बैंक दोबारा से उन्होंने उसके ऊपर ज्यादा ध्यान दिया और एक बड़ी रेयर एब्नॉर्मैलिटी पकड़ी। So whenever you are seeing coarctation, उसमें खैर ऑब्वियसली जैसे पहले है कि आप क्लिनिकल एग्जामिनेशन जरूर करेंगे, ईसीजी देखेंगे, एक्सरे चेस्ट देखेंगे रिब नॉचिंग के लिए, मगर एको के ऊपर जब हम देख रहे हैं तो यू मस्ट लुक फॉर एडिशनल कंजेनिटल एब्नॉर्मैलिटीज, बाइकस्पिड वाल्व है, कोई और उससे रिलेटेड एब्नॉर्मैलिटीज हैं या नहीं। सो इट्स अ नाइस केस।
I think Shahbaz साहब एक चीज और इम्पोर्टेंट है, आई थिंक जूनियर्स के लिए दिस इज वेरी इंपॉर्टेंट टू लुक एट द पल्सेस। अगर पल्सेस ब्लड प्रेशर, मेरे पास 2-3 पेशेंट आई हैव सीन जिनको के सारे शहर में घूम रहे थे अनकंट्रोल्ड हाइपरटेंशन के साथ एंड किसी ने उनकी पल्सेस चेक नहीं की थी। तो अगर आप पल्स का डिले देख लेते हैं तो आई थिंक उससे भी आप काफी हद तक पहुंच सकते हैं एंड फिर आप इंसिडेंटल फाइंडिंग नहीं होगी एको पे। बट एको करने वाले लोगों के लिए इट्स वेरी इंपॉर्टेंट इफ समवन इज कमिंग टू यू विद अनकंट्रोल्ड हाइपरटेंशन, especially a young person, then always look for coarctation of aorta. And इसमें जो इस केस में रियलिटी ये थी कि इसमें जो डबल orifice mitral valve था, that was really interesting and I think that's a very rare thing. यहाँ से एक दो लोग और कमेंट्स देना चाह रहे हैं तो मे बी डॉक्टर लुकना जी।
जी जी।
Thank you, Saba. Very interesting case. I would like to add that in population, you may not have that the maximum gradient in the presence of good collaterals. If you have any good collaterals developed, then in the presence of even severe population, you can miss the maximum gradient because of the shunting to the collaterals. Another thing I can add that in the transverse echo, short axis mitral valve is the best way to identify all the scallops of the anterior and the posterior mitral ligament. This is the only view of the echo on which you can simultaneously see all the scallops. You can identify the origin of the gland and the pathology and the physiology. So short axis mitral valve often miss on the echoes, but always focus on this view. So many times you can get the diagnosis just on the basis of the short axis mitral valve.
Just to add on, I think we must make a habit to get a suprasternal view. This we usually don't do. Parasternal, difficult, that's all. So, on suprasternal, it is a bit difficult at times, especially for adults. Put a pillow underneath, get the neck extended, all the things. But we must make a habit that the suprasternal view and finally the subcostal view should also be, we should make a habit of it. My teacher, Professor Saba, will never do an echo, never complete an echo until he has done these two views in every case. So make a practice so that when you come across a case of operation or where it is difficult to imagine, then you have got good practice to do suprasternal.